So we are slowly going back to something normal. Slides don't seem to be advancing. Maybe I'll get whoever's controlling it to advance the slides, but it's really going to be a new normal. It's no longer so much fun to be sitting in Trinity Bellwood Park in Toronto, for example. So where is it going to go? It's the next slide. Crohn's and Colitis Canada, I think, has been very informative about this already, and I won't go into this in detail because it's already been addressed by Dr. Benchamal. There's some very good guidance here for some specific things like returning to work and returning to school as we start to reopen the economy. The next slide. But Canadian Association of Gastroenterology has put out some guidance, not specific to IBD. That task has really been taken on by Crohn's and Colitis Canada, but one set of guidance that our professional organization, the Canadian Association of Gastroenterology, put out was, how do we restart endoscopy services? That's going to be very heterogeneous across the country. My colleagues in British Columbia tell me that they're almost back to normal in terms of their service. We in Ontario are probably doing still between 15 and 20% of the endoscopy volume we did before, which has severely hampered access. And so we've had to go into a triage mode of trying to sort out who really needs the procedures now and who can wait. And I won't go through this in detail, but I'll just point out to all of you that there's a priority one, which is the things we have to do. Patients, it's a life and death situation. So in any situation, you just have to get these procedures done. But there is a next category, priority two, things that we should be doing. And within that priority two is, in fact, investigating IBD. If we need to look at the disease in order to make a treatment decision, that is now a procedure which has sufficient priority to make it to the top of the list, and we still have ways of getting these procedures done for IBD patients if they need to be done. So I think that's important to know, to hear about all these closures, but there are still ways to access all the things we need to do for the patients who really need it. Next slide. So this next image has already been shown, Dr. Bruce, I won't repeat it, but just to point out that Canada was a part of this IOIBD survey, so the opinions of some of your physicians were included in this, and I think Canada was among the jurisdictions in the world that really did see this rapid uptake of particularly telephone care as well as video care, and again, as was pointed out, this is likely to continue, at least in the opinion of your caregivers. Also, it's interesting, most of the virtual care that we've been providing has actually been by telephone. We offer our patients the choice of video or phone, and it's interesting to me that well over 90% of our patients actually opt for telephone care, which is even more convenient perhaps than having to be in front of a computer screen at a scheduled time. But I think there are pros and cons with that, and I like Dr. Brew, really prefer the video communication. I think there's so much nonverbal communication that happens in those discussions. But in fact, most of the virtual care we've been providing is by telephone, and has been discussed, the Ontario government, as many across Canada, have now started to reimburse telephone care, whereas they didn't used to. And I suspect that most of those fee codes will remain following the pandemic. So I think a mixture of telephone and video care, as well as in-person visits, is going to be the way to go. So next slide. So we're talking about telephones. I thought I'd point out to Dr. Brew that a Canadian invented the phone in 1876, Alexander Graham Bell, so it's a Canadian device. There have been some very famous telephones through history, but in 2020, of course, we have even better technology that has facilitated communication. So, this pandemic, if it had happened 10 or 20 years ago, would have been managed very differently than it is now that we have tools like our smartphones and the technology with which you're watching this presentation today, that they're available to us. So just the next slide. And again, kudos to Crohn's and Colitis Canada. This app has been developed as part of a larger initiative called the PACE Initiative, which is across a number of academic centers in Canada, trying to improve care and improve the quality of care across Canada for IBD patients. And one of our mandates was to help us develop communication tools between patient and provider. This app, MyGut, many of you probably already have it on your phones, but and Dr. Bruce spoke to a number of the apps which have been developed around the world. This has been started in Canada and hopefully spread through the world. but it allows you to track your daily activities, to receive educational resources, to respond to questionnaires and ask about your disease activity, about the quality of life, for example, and can generate summary reports. And the next phase of this is going to start looking at this bidirectional communication between you and your healthcare provider using this app to collect data. So it's another tool apart from the scheduled e-visits that will hopefully be available to you as patients in the near future. I encourage you to look at this app. So next slide. So this is really my last slide, because I know we need time for questions. So what do I think the post-COVID IBD universe is going to be like in Canada? Probably similar to other places around the world. There no question is going to be an integration of telephone and video visits in our care. I too have long wanted this. It seems silly to me that, well, I don't have people flying 12 hours to see me, but I do have people driving several hours to see me, and it just seemed a colossal waste of time and human energy to do that. We need to do this. I think it's much more efficient. Clinical trials as well. We, like many of the people on this call, participate in studies of novel therapies, and the clinical trials have also had to modify to allow people to participate remotely, and that's a whole other topic for conversation. But I really think this is an opportunity, this spoken hub engagement of big teaching centers and specialized IBD care. So now it really evens the playing field. You know, you really shouldn't be getting better IBD care if you happen to live in downtown Toronto versus northern Canada, because now there should be pathways and technologies for you to get an opinion from really anyone in Canada. So I really hope that this will help to level the playing field and allow people to see different specialists across provinces and perhaps between provinces much more easily. More reliance on non-invasive measures. This is probably a message to speed up, like stool testing and blood testing. I've already mentioned the patient support programs for our patients on biologic therapy, which have become very useful partners. And there's some probably nuances with regard to how your IBD gets treated that might be different. I think there's going to be, in general, a continued interest in safety and concern for safety of therapy that may lead to even more judicious use of things like steroids that, as Dr. Benchamal mentioned in the beginning, are potential risk factors for infection in general. We may be trying to be more targeted in the patients we keep on more than one medication for treatment of their disease. And again, I think safety is going to come up in our discussions more. I do probably think that, you know, knowing whether you've been exposed to coronavirus might become part of your kind of assessment in IBD clinics, and to know whether you're still at risk of infection. And hopefully, this is aspirational, that we're going to be reminding you to get your coronavirus vaccine, as we do to remind you to get all the regular scheduled vaccines when you have IBD.